This is Dr. Murphy with the Department of Anesthesiology at the University of Kentucky. And this podcast is covering the anatomy for lung isolation and is directed towards the PGY2 first week rotation. This is the primary objective for this podcast. And the core references for thoracic anesthesia include the Chapter 26 in Hensley's 5th edition, A Practical Approach to Cardiac Anesthesia, as well as Chapter 59 in Miller's textbook 7th edition, available on the Clinical Key access system. First, some basic anatomy. The right lung has 3 lobes, the left lung has 2 lobes. The function of the lung is split 55%, 45% right to left. And this cartoon from the textbook on thoracic anesthesia brings up the mnemonic APOM, AMAPLE, which you can associate with trees, a palm tree, a maple tree, the bronchial tree. And there are some average diameters shown on this cartoon. This cartoon, also from Benjamin's textbook, shows that APOM stands for apical, posterior, anterior, lateral, and medial subsegmental bronchi of the upper and middle lobe, and AMAPLE refers to anterior, medial, apical, posterior, and lateral. Now, this level of detail is not entirely required of anesthesiologists. It's much more the field of pulmonologists and thoracic surgeons. However, this is essential information for the thoracic anesthesiologist. The average distance from the incisors to the vocal cords is 15 centimeters, and the average distance from the vocal cords to the carina is 12 centimeters, so a total of 27 centimeters. The distance from the tracheal carina to the takeoff of the left upper lobe is about 5 centimeters, giving you a greater margin of safety on the left side. Getting back to the right upper lobe, it has 3 orifices, and you will find in the literature that this became essential information for knowledge for anesthesiologists in the mid-90s. And another cartoon showing the average distances and diameters, long known information. Now, a complete fiber optic bronchoscopy examination, as far as placement of a double lumen tube is concerned, would be to at least identify these structures on this slide. And as the legend in the figure shows, and as you will very quickly learn to identify, the tracheal carina is the first thing you see, and is shown in picture A at about 1 o'clock. And at about 4 o'clock, you can see letter E showing a view of the left upper lobe and left lower lobe. This is something that you would visualize through the bronchial lumen of a double lumen tube. At 6 o'clock, you can see the orifices of the right middle lobe and right lower lobe, depicted by the letter D. And Closer to 9 o'clock is the right upper lobe bronchus, and depicted by the letter C, we can visualize the apical anterior and posterior segments of the right upper lobe. Shown by this blue arrow. However, anatomy is not constant and there are variations on a theme. The right upper lobe bronchus can come off the trachea, and this bronchoscopic photograph shows the apical segment of the right upper lobe coming off the trachea with the next orifice containing the anterior and posterior segments, and in fact the most inferior orifice is the right main. Quite disorienting. This study from Brazil is a nice summary of the variety of congenital anomalies. The practical aspect of this from a bronchoscopic point of view is that many practitioners will do a bronchoscopy before inserting a double lumen tube, either through the double lumen tube or perhaps through a single lumen tube if there's difficulty in placing a double lumen tube. Many practitioners also rule out the presence of a right upper lobe anomaly when attempting to place a right-sided tube because of the usual anatomical challenges to placing a right-sided tube. Before you get the opinion that the right-sided tube is difficult to place, it is not. It is not difficult to place. In fact, it is anatomically the most likely place for a foreign body to end up, be it a peanut or some other foreign body. And likewise, when the left-sided tube is placed, it doesn't always go into the left side. Sometimes it ends up on the right side and presents some distraction and some confusion when placing a bronchoscope to confirm the position. The topic of placing a double lumen tube, or how I place a double lumen tube, will be covered in a separate podcast. This next slide shows another anomaly that prevented the isolation of a right lung with a bronchial blocker. Now these tubes are large. A double lumen tube with the nominal French size 35 has an external diameter of 11.7 millimeters, and this is just about the same size as an 8.5 French 8.5 internal diameter single lumen tube, which has an external diameter of about 11.4 millimeters. So if you have a patient who does not have a glottis that is large enough to accept a 8.5 internal diameter single lumen tube that also has an external diameter of 11.4 millimeters, then you should not expect that a 35 French double lumen tube, which is the smallest of the standard size ones that we have, the one that accepts a normal pediatric fiber optic scope, this is not going to fit. And this photograph shows you the sizes of relative sizes of 8 millimeter, 35 French, 10 millimeter internal diameter, and finally the 41 French double lumen tube. So you get the idea of how large a 41 French tube is, yet it is the recommended tube size for an average size male. So this slide shows 3 bronchial blockers. On the far right hand side is one of the first modern bronchial blockers developed by Dr. Arndt, and although it is hard to see, it has a nylon wire loop at the tip going through the central channel, and this is used in the positioning of the tube by passing the bronchoscope through this loop. We also, at the University of Kentucky, we also have the middle bronchial blocker, brand named, made by Fuji, and it has a bit of an angle on it, which makes it a little bit easier to direct one way or the other. And on the left is the Cohen bronchial blocker. This is one that is also able to be directed, but we do not have this at the University of Kentucky. These are just some pictures of the Cohen flexi-tip endobronchial blocker, and primarily I presume that this is a pretty good example of how that bronchial blocker can be directed from one side to the other. This is an excellent review article, and I recommend it to you. It is 13 years old. However, it is written by one of the premier experts in thoracic anesthesia. So how do you learn bronchoscopic anatomy? First, practice using a bronchoscope on the patient that you put a double lumen tube in. You should watch the surgeon in those cases where a double lumen tube is not being placed, but a video bronchoscopic examination is being performed, and you can learn a lot about bronchoscope handling. You can attend workshops at the ASA. I recommend that you use the website number 4, which is depicted in photographs in the Hensley textbook, and which originates from Dr. Slinger's institution at the University of Toronto. And while there are simulators, I'm not very familiar with them, and I don't think we have any at the University of Kentucky, at least not within our department. This slide here is meant to give you a bit of a flavor of the external diameters of different video bronchoscopes, and it does show that that there are quite a range, and you just have to be knowledgeable about what size bronchoscope fits in what tube and what lumen of which tube. Sometimes, if you're in doubt, it would be appropriate to do a test. Place the bronchoscope through the double lumen tube. Make sure that it's well lubricated with silicone endoscopic lubricant, not water-based Surgilube, because water-based lubricants dry out, become sticky, and difficult to advance or retract the bronchoscope. There have been cases of the bronchoscope becoming trapped in the ventilation slot or the Murphy eye of endotracheal tubes, such that in order to remove the bronchoscope, the tube had to be removed. So you have to be careful with the advancement and withdrawing of these bronchoscopes. This is the screenshot of thoracicanesthesia.com, and it is a bronchoscopic simulator online, which you can use to increase your knowledge about bronchoscopic anatomy. So this is the end of the PGY2 podcast on anatomy for double lumen tubes. Thank you, and I hope that this short podcast is of help to you in your cardiothoracic rotation PGY2 level.